In this episode of EHA Unplugged, we will revisit a spotlight talk from EHA2024. Dr. Elisabeth Schorb from the University Medical Center in Freiburg presents on the first-line treatment of primary central nervous system lymphoma, which has seen tremendous advances in the last years.
My aim is to share with you my excitement about the first-line treatment of primary central nervous system lymphoma and share some experience that might be inspiring and helpful for you, whether in PCNSL or even in other diseases. There have really been tremendous advances in the first-line treatment of primary central nervous system lymphoma during the past years. But of course, all of you know there's been a lot of data, a lot of clinical research behind it. It's been a real fireworks display, and my aim is to get to the heart of this great story in just about the next 15 minutes. As you will hear in my talk, all of these advances would not have been possible without international collaborations. And that is why I'm so pleased to stand here at this stage and share this story with all of you. From my point of view, PCNSL is really a special disease. This is mainly due to the cause that it is not a disease you would have to deal with on a daily basis. The incidence is quite low, so by definition, it is a rare disease. But it's also a special disease because of its location. Time is brain. The central nervous system does not allow treatment or delay, and therefore requires multidisciplinary and prompt action. And that means that making the diagnosis promptly and starting the treatment quickly is very important. But when we get to the point of starting treatment, everything we have learned about treating systemic aggressive lymphomas in our careers does not really apply for PCNSL patients. There are barriers to overcome. The blood-brain barrier rejects the treatment we know from treating systemic aggressive lymphomas, such as R-CHOP, for example. This makes them an inadequate treatment options for our PCNSL patients. And it's precisely because of the rarity of the disease and its special challenges that all the impressive advances that have been done in the field of primary central nervous system lymphoma have only been achieved by thinking outside the box, by driving forward investigator-initiated clinical research, even though the rarity of the disease made patient recruitment even more difficult, and conversely, the pharmaceutical industry's interest in testing new drugs lower than in many other hematological diseases. When I started to look at primary central nervous system lymphoma about 15 years ago, the knowledge of treatment options was still very limited. Data was scarce because of the rarity and the nature of the disease, which made it difficult to conduct clinical trials and to generate evidence. At that time, despite many attempts to change the situation, R-CHOP was still the benchmark for first-line treatment of systemic aggressive lymphomas and would remain so for many, many years. A similar picture has emerged with regard to the treatment of other brain tumors, such as gliomas, for example, where unfortunately very little progress has been made during the past years, despite a large number of patients. In contrast, the treatment of PCNSL has really exploded during the past 15 to 20 years. Fortunately, when I completed my studies, I met a group of really inspiring people who were working on this rare disease, who were thinking outside the box, and who had the courage to take a path that was known from other diseases, but was completely unknown in the context of treating brain tumors. And this group of people completely reinterpreted the treatment principle of treatment intensification in terms of the blood-brain barrier. And I saw how difficult this path could be at a time when clinical research was still struggling at many places. but they remained motivated and passionate about clinical research in primary central nervous system lymphoma. And I'm so grateful that they captured me with their enthusiasm and their motivation, and that I became a part of this wonderful international study group. At the very beginning of my hematological career, then 45-year-old patient symbolized this motivation. He was diagnosed with PCNSL in 27 and was treated with high-dose chemotherapy and autologous stem cell transplant within the CNS-NHL trial. This patient was young and athletic, and his biggest wish was to be able to lace up his running shoes and go jogging and compete as soon as possible after treatment. And I watched as his disease went into complete remission. And just a few months after stopping high-dose chemotherapy and autologous stem cell transplant, he would lace up his running shoes, go to the starting line, and ran a half marathon. He had his old life and his dreams back, and I could really understand his joy. And it was in that moment that I realized that I was just at the right place, and I really wanted to help more and more PCNSL patients to get better and better treatment options. And that motivation has led me on an incredibly interesting journey that I would now like to share with you. The treatment of PCNSL today is based on two pillars, as for other hematological diseases as well: induction treatment as well as consolidation treatment. In contrast to the first-line treatment of systemic aggressive lymphomas, an incredible amount has happened during the past years. A disease that is fatal within a short period of time if left untreated has become a curable disease. After the CNS-NHL trial, which I've mentioned earlier, and from which my first PCNSL patient benefited so greatly, I was able to see firsthand how international collaboration has enabled further progress to be made in the treatment of this disease, gradually improving standard of care and thus the prognosis for our patients. I was able to enroll patients in the ILSG32 trial, which investigated an intensive induction treatment comprising methotrexate, cytarabine, rituximab, and tiotepa, and established the so-called matrix regimen as standard induction treatment in many, many countries. Around the same time, we had the honor of publishing the results of the CNS-NHL trial, which would also revolutionize consolidation treatment in the years that followed. The results of this trial confirmed my subjective impression that intensification of treatment with high-dose chemotherapy and autologous stem cell transplant could really produce excellent long-term outcomes and a substantial chance for a cure. A major milestone in the history of PCNSL treatment. A disease that was rapidly fatal if left untreated was transformed into a disease with a long-term overall survival of nearly 80% after 5 years for eligible patients. This set the stage for further development in Europe and beyond. Subsequently, two randomized phase 2 trials, namely the ILSG32 and the French PRECISE trial, compared myeloablative consolidation with the former treatment standard of consolidating whole brain radiotherapy. As a result of the trial findings, whole brain radiotherapy became less important in weighing the risk-benefit assessment of each treatment modality. And this was mainly due to the fact that the long-term consequences of whole brain radiotherapy in terms of neurotoxicity became more important as the survival of our patients improved. Consequently, consolidating whole brain radiotherapy is now only reserved for specific cases. And all these developments have only been possible by pooling European forces. My view of these European collaborations was sharpened by an incredibly educational time on the EHA's clinical research training in hematology program, where I met inspiring people and gained important insights into the clinical research landscape. I am incredibly grateful to have had this experiences that have shaped me to this day. Based on this scientific and personal experience, I was able to participate in the world's largest randomized phase 3 trial to further investigate consolidation treatment, the MATRIX trial. I have learned not only how important supportive care and physician experience are in addition to effective combination treatment, but also how exciting international collaboration can be. In particular, the MATRIX trial looked at whether high-dose chemotherapy and autologous stem cell transplant as consolidation was really necessary, or whether even non-myeloablative approaches could produce similar or even better results. The result of this trial is really a milestone in PCNSL treatment, not only because this study can be considered a real successful European collaboration in a rare disease, but also it achieved something that had not been seen for years in the treatment of systemic aggressive lymphomas or in other brain tumors for decades. A clear advantage, not only in terms of progression-free, but also in overall survival for those patients who were treated with high-dose chemotherapy and autologous stem cell transplant. And this late-breaking news was presented at the ASH annual meeting in 2022 and will be fully published shortly. And so many people have benefited. But the marathon runner I told you before was young, athletic, and fit. And as you can imagine, not all PCNSL patients meet these criteria. And over the course of my career, I've been particularly motivated to bring promising treatment options to these people as well. Recent and ongoing studies have aimed to make highly effective therapeutic approaches available to a larger group of patients. The recently published phase 2 MARTA trial investigated or showed that a short induction with rituximab, cytarabine, and methotrexate, followed by age-adapted high-dose chemotherapy and autologous stem cell transplant, was feasible and effective even in patients above 65 years of age. We have also learned that the very early phase of treatment is crucial because we do still lose many patients there. This is the basis for ongoing studies with the aim to minimize early toxicity, like in the European Optimate trial. And international studies are also investigating how the addition of novel targeted agents can further improve induction treatment. In addition, it will be very interesting to learn how novel biomarkers and therapeutic approaches like CAR T-cell therapy or even bispecifics in the future will further shape first-line or further treatment of PCNSL patients. And from my point of view, it speaks volumes that this disease, with data on circulating tumor DNA in PCNSL, made it even to the plenary stage of the ASH meeting in 2021, where this rare disease was heard on this great hematological stage. Inspired by my experience over the past 15 years, I have witnessed a veritable firework display of PCNSL development. I am very positive and incredibly excited about everything that awaits us in the upcoming years. As you can see, we do see things different now, and we've gone places we couldn't have dreamed of before. I could never have imagined that I would be standing here today at this stage reporting on these great advances in the field of primary central nervous system lymphoma. And what's 15 years in clinical research? It's really a short amount of time. And that is why I'm standing here today. And with this experience, I have no doubt that in 15 years' time, we will be able to reach even different heights. And that's what I do hope for in the future, not only for PCNSL, but for other diseases as well. I hope I have passed on you some of my enthusiasm. And I will be delighted if you take away with you the idea that it is possible to break barriers and seek out the great challenges. It is important to remain curious and ambitious, to be cooperative and collaborative. After all, interacting with people and colleagues make us better clinician scientists and clinicians. Even if it can sometimes be difficult, stay tuned, stay in touch, because your investigator-initiated ideas can make all the difference. And I would like to thank you for listening and thank all of those people who just joined me on this incredibly interesting journey.
If you have a patient where you're in doubt about the fitness of the patients beforehand of the treatment, would you choose for a more intensive induction treatment, or would you choose for a less intensive induction treatment with all aims to get to a consolidation phase of your treatment?
Well, when we're talking about consolidating intensive treatment with high-dose chemotherapy and autologous stem cell transplant, I'm really convinced of the fact that we should aim to go for. So I would be more likely to just reduce a little bit of intensity of induction treatment to really reach high-dose chemotherapy, because we know this component is really important. I would probably do a kind of a pre-phase with rituximab and methotrexate, just have an idea how the patient is, how everything is working out, and then decide if I can add, for example, cytarabine, or maybe I will go on with a MTX rituximab protocol for the further steps. That's how I'm approaching these situations.
What is your strategy for elderly patients who could not be treated by autologous stem cell?
We really still need a lot of more data on it, because it's not that satisfactory at the moment. Well, we do have a phase 3 trial where we are comparing the RMP protocol from the PREMAIN study with an intensified regimen. So we would go, at the moment, we would go for PREMAIN for RMP. But of course, we would be very delighted to add other drugs. We do have another trial adding lenalidomide and tafasitamab, just a little phase 2 trial.
I'd like to know, what is your strategy for the patients who relapsed, early relapsed after intensive treatment with autotransplantation?
Yeah, well, speaking about early relapses, I think the CAR T cell approach is quite promising. We do have a certain amount of time after high-dose chemotherapy, so we would go even for another autologous approach as well. And we did see really brilliant cases. So. But if it's an early relapse, I would really go for CAR T cell therapy if available. Thank you.